All right, good afternoon, everyone. I'm going to go ahead and get started as people join the link. Thank you for joining Health for a Change Beyond the Exam Room, how the AMA is tackling social determinants of health. My name is Allie Wells. I'm the Communications Director at the Foundation for a Healthy Kentucky. We are very excited about the speakers we have joining us today. Dr. Alexander Ding is a member of the AMA Board of Trustees and a Kentucky resident. He is a board-certified diagnostic and interventional radiologist and the Associate Vice President for Physician Strategy and Medical Affairs at Humana. In his role at Humana, he leads a team focused on physician engagement, empowerment, advocacy and wellness, the advancement of value-based care, and organizational strategy in clinician recruitment and retention. Jennifer Brown Esquire currently serves as the Director of Health Equity within the Advocacy Group of the AMA. In this capacity, she drives leadership and direction for the Advocacy Group to support the continued development and implementation of the AMA's health equity advocacy work. I will turn things over to them in just a minute. I've got a few housekeeping things to go over. If you have any questions during the webinar, you can put them in the chat and we will address all questions at the end. There are no pre-approved CE credits attached to this webinar. However, I can provide a certificate of attendance. My email is up on your screen right now. So if you would like that certificate, please just email me once the webinar is over with your name, and I will get that to you as soon as I can. And I will also include these instructions in a follow-up after the webinar is over. And to tell you a little bit about the Foundation for a Healthy Kentucky, we are a nonprofit organization funded by an endowment that aims to transform our state so that every Kentuckian has what they need to live a healthy life. Our mission is to address the unmet health needs of Kentuckians, and our two focus areas are access to care and children's health. We do our work through policy advocacy, we build partnerships and bring together constituency groups. We fund research and data, and we fund and support community intervention projects that work to improve the health of Kentuckians. So with that, I'm going to turn things over now to our speakers to dive into the topic of the social determinants of health.
Great. Well, thank you so much, Allie. Good afternoon, everyone. Thank you so much for the introduction. Thank you to your board of directors, your community advisory council, and the foundation team for your vision for the future and really for facilitating this important talk around our shared goals for a healthier future. We're also thank you all as our virtual audience today for joining us this afternoon for your commitment to these issues that we're going to be talking about today. So as Allie mentioned, I'm Dr. Alex Ding. It is a real pleasure to be with you today to talk about the AMA's efforts to address social determinants of health as it impacts the quality of life and as that impacts our ability to lead a healthy life. Now, I know that we've got members of our audience from different areas of healthcare and society, and I'm sure that despite this diversity we're all here for the same reason, which is to help people live healthier lives. And if we're doing it right, to build stronger communities in that process. And so before I move on to my presentation, I thought I'd share a little bit about why I joined the field that I'm in, why I got into medicine, and why I'm so passionate about the health of this nation. So as Ali mentioned, I'm a diagnostic and interventional radiologist by training and by specialty. I practice on the faculty practice at the University of Louisville. I got into healthcare and this field specifically because as a kid, I loved science and technology. I loved understanding how things worked. I loved cool new technology toys. Really loved understanding human anatomy and physiology, which to me was really about understanding the mechanics of the miracle of life and how people work inside, and using cutting edge technology to do that was even more cool. But, an interesting thing happened when I went to medical school. While most of us learn about the biological and scientific model of medicine, where I went to medical school, they were touting this new way of understanding medicine. It was called the biopsychosocial model of medicine, which it turns out is that it's not just the biology that drives your health, but it's all of the things that happen in your life, including your interactions with others, the connection between mental health and physical health, and that so many other things in your day-to-day life end up affecting your health, which is now what we refer to as social determinants of health. And so with that understanding, I feel I've got a better holistic understanding of what drives health, which is of course what we're going to be talking about today. So I've been here in Kentucky for about 5 years now. We first moved here because even though I was a subspecialist, I really understood that investment in primary care and moving our healthcare system into a value-based care sort of system would truly allow the health system to incentivize keeping patients healthy rather than just intervening when patients are getting sick and providing reactive care. And so I joined a company here in Kentucky to work on exactly that. And I found that this value-based care model allows the healthcare system to actually pay more attention to social determinants of health and having healthcare professionals focusing on those needs in addition to those traditional medical needs. So, as a physician, I know that when a patient comes to see me, they are bringing with them all of the factors that are impacting their quality of life. And understanding these health determinants that shape a patient's well being is really essential to improving that patient physician relationship and improving the overall health of populations. And so, what are social determinants of health? Well, they are social, the economic, the environmental factors that contribute to health and health disparities. They affect quality of life, they affect the longevity of individuals and communities. And so, some examples of these are poverty, discrimination, education, transportation, social isolation, and environmental factors like pollution or climate change. And the AMA is committed to helping address these determinants of health, often in partnership with other organizations to help all people achieve their optimal health. And so I shared a little bit about my personal background and why I'm so passionate about what we're talking about today. I also want to share with you the AMA's background and why we're continuing to lead the charge for better outcomes for physicians and their patients. Next slide, please. So the AMA, founded in 1847, is the largest and most influential physician organization in the United States. At its original founding meeting, they adopted a code of medical ethics, which articulated the values that still guide medical practice today. This code of medical ethics is also, in large part, a basis of the legal framework for a lot of medical practice laws in the United States, even to this day. And quite frankly, also serves as a template for a lot of these sorts of frameworks and laws throughout much of the world as well. We host a House of Delegates, which some people refer to as a Congress of Medicine. This represents about 190 state and medical specialty organizations all throughout the United States. As a convener of so many medical organizations where we get together to deliberate our profession's policy positions, all in all, this ends up representing about the voice of about 95% of all physicians in this country. And that work ends up influencing policy decisions about medical practice, patient safety, and public health at both state and federal levels. The AMA has been doing this work for a long time and has been involved and helped to lead or help to advance a number of things, including major public health initiatives to curb smoking, to promote vaccinations, to address the opioid epidemic, to improve automobile safety, and to protect patients and physicians from pandemics, including most recently COVID-19. Next slide, please. So for over 178 years and counting, the AMA has risen to each extraordinary moment in medicine by focusing on advancing science and research, standardizing physician training and medical education, improving public health, and uniting the profession around a core common set of ethics. And so, since our founding in 1847, we remain the physician's powerful ally in patient care, and we are here to support our docs to better take care of their patients. We are working in really three big important ways to support physicians and patients and reform our healthcare system as well. Number one is through removing obstacles that interfere with patient care. Number two is leading the charge to confront public health crises. These include things like chronic disease, persistent health inequity, emerging threats, including pandemics. And thirdly, through driving the future of medicine through improved medical education, innovation, and physician training. Next slide, please. And so as we think about the future of our healthcare system, we have to consider the health needs of our nation in the decades to come. I think there are also a couple of concerning trends that we've got to pay attention to as well. So I think it's no surprise to anyone here that our population is aging. So by the year 2050, the US population over the age of 65 is going to double. That is rising from 16% in 2020 to 22% by 2050. All at the same time, our nation faces an ever-growing chronic disease burden, widening income inequalities, rising healthcare costs, a shrinking medical workforce, the threat of future pandemics, especially increased in light of climate change, and some alarming statistics related to increasing maternal mortality and declining life expectancy in this country. Next slide, please. And although we as a country are spending a significant percentage of our gross domestic product, our GDP, on medical services, much more than any other developed country, the outcomes are really not the greatest. In fact, they're amongst the lowest for developed countries, for our peer countries that are we compare ourselves to. And what we spend on medical services is really the downstream effects of multiple complex social factors that go into determining a person's health. So even though about 90%, you can say 88%, 90% of the healthcare spend, the healthcare dollar is spent on medical services, healthcare itself is actually estimated to contribute about 20% to a person's overall health. So here on the right, you can see that there are socioeconomic factors such as education level, job status, family and social support, income levels, and neighborhood safety probably contributing the most to a person's actual health, contributing more than double the impact on health compared with healthcare services itself. Additionally, lifestyle behaviors, things like tobacco use, alcohol use, diet and exercise, drug use, sexual activity, also affect people's health more than healthcare services themselves as well. And so you can see really more holistically all of the different factors that truly go into determining someone's health. You'll even see that genetics is probably a relatively small contribution here. I haven't even listed it here. But all of these non-healthcare related factors, around 80% of what determines a person's health is actually impacted by social determinants of health. And it's probably more than that, because if you talk about the quality and access to healthcare and the screen bucket of healthcare services, social determinants of health probably affects that as well. And so this explains a startling statistic that those of us that live in Louisville can understand in terms of kind of the disparities we note in our own neighborhood. So if you live in the west end of the city of Louisville, there's a life expectancy that is about 15 years lower than those that live just 5 or so miles away in the part of the city that I live in Cherokee Triangle, the Highlands, and St. Matthews. And the good thing, despite all of that being said, is that we are seeing that now more and more healthcare entities, healthcare organizations are beginning to adopt this whole person care model. Next slide, please. And so when we think about social determinants of health, you can think of a framework of how ingrained something is into society and how proximal it is to healthcare itself as kind of that framework. So we think of upstream as being more removed from medical care, but just as deterministic, if not more, of health and determinants of health or sickness that will then flow down into the need for clinical or medical care. So at the way top, you've got the structural determinants of health. These really encompass the social and political context in which one lives their lives, things like cultural values, labor and employment policies, public policies. A little bit further midstream, you've got social determinants of health, which are conditions in the environment in which people live that affect a wide range of health, functioning, of quality of life, of outcomes, and health risks as well. So these are things like living conditions, access to healthcare systems, social cohesion. And then as you move further downstream, you get to health-related social needs. These are kinds of things that are more proximal to medical care or clinical care, things like food insecurity, transportation access, and health harming conditions as well. And so then you move further downstream, and that is where most of us who work in clinical care and medical prevention really work. And you'll see that that is at the bottom of the river of where all of this ultimately flows down into affecting people's health. And so to improve health, we've really got to be able to move upstream as well. We've got to be able to focus midstream and on the upstream influences that determines people's health as well. Next slide, please. Now, as I was doing my research on your organization and your priorities and goals, I noted that one of your policy priority areas in 2025 under the social determinants of health bucket was on sensible gun control. And I thought maybe we'd start here as a topical area where we, the AMA, are very much in alignment with your efforts here. So, you know, as the AMA works to address some of these social and structural determinants of health, we continue our advocacy to promote stronger communities and healthier neighborhoods, which includes addressing the impact of gun violence. So the AMA has called for efforts to curb firearm violence since the 1980s. And in 2016, we officially labeled gun violence a public health crisis. In 2022, we established a new task force, which is focused on firearm violence prevention, which includes firearm-involved suicide. And we convened this task force with other clinical physician leaders, high-level staff from several national medical associations to really increase that collaboration on topics related to firearm safety. Next slide, please. Now, as the co-lead of the AMA Gun Violence Task Force, I really am committed to creating safer spaces for our families and for our children. And as a father of two young children, it's something that I do lose sleep over. And that there's a statistic that is particularly appalling to me, which is that firearms is now the #1 cause of child and teen death in this country. Car accidents have been the #1 cause for decades, but this has been surpassed by firearm injury and death since 2020. In fact, it is this statistic that we're using for a first of its kind PSA campaign to address this issue. So we've partnered with the Ad Council and unveiled an Agree to Agree gun violence prevention initiative to reframe this topic as a nonpartisan one that starts with the initial agreement, no matter where you lie on the political spectrum, that gun violence as the leading cause of death for children and teens in this country is not acceptable, and that needs to change, and that is the start of this common ground to see it not so much as a divisive two-sided debate, but that starting with agreement on this one item, this one statistic, moves the conversation productively forward. And so you can check out the campaign. It's running on TV. It's also available at agreetoagree.com. It's just launched a couple of weeks ago. We're excited about that. So as physicians, we see and experience really this firearm trauma firsthand. We treat gunshot victims in our emergency departments. We provide psychiatric care to the survivors. We console families of the deceased. And physicians across the country really make split-second decisions every single day to treat and save victims of gun violence. Next slide, please. And over the past 2 decades, the AMA has developed numerous policy recommendations to reduce firearm trauma, injury, and death. And it is an area where we remain concerned, engaged, we've prioritized, and are always looking for new and more partners and allies to push forward on this important public health crisis. Next slide, please. And so switching gears from firearm injury as one manifestation of social determinants of health, kind of zooming back out again, here are some other social determinants of health that are more structural and explain some of the significant health disparities in this country, including that difference in life expectancy that I mentioned in my own city of Louisville. So lack of access to medical treatment or testing, disinvestment in Black and Brown communities, segregated housing and lending practices, lack of physician offices, lack of public transportation access, health food deserts that surround under-resourced neighborhoods. And these, amongst a host of other factors, are a key reason why historically marginalized groups suffer higher rates of heart disease, diabetes, and other chronic ailments, which affects their life expectancy. Next slide, please. And so in order for us to make sound decisions from SDOHEA, we really need good data and a way to standardize this information that is collected about social determinants of health. And so one of the things that the AMA has done is We are the founding member of what's called the Gravity Project. This is a Robert Wood Johnson funded initiative. It's got more than 2,500 participants from organizations and entities representing healthcare, social services, payers, technology vendors, and government agencies that are working to develop consensus-driven data standards that support the collection, use, and exchange of social determinants of health data. So this national public collaborative develops consensus-based data standards to improve how we use and share information on SDOH. Some of the challenges in this data include a lack of standardization of data collection and storage, data sharing, access and comfort with digital solutions amongst the stakeholders, social sector capacity and capabilities, set management, and the unnecessary medicalization of SDOH. So the Gravity Project really focuses on the first two bullet points, which is the standardization and the data sharing piece of it, which includes technical aspects, developing terminology, validating and testing concepts through pilots. And this approach is intended to address those barriers to addressing SDOH that are caused by the lack of terminology standardization and clinical relevancy as well. Now, the AMA recognizes that collaboration is absolutely critical to the success. And so recognizing that these problems are so foundational and so large as it relates to data and data quality, that going it alone is not going to be an effective way to tackle this. And so that's why webinars like these, organizations like this and yours, are really so critical in creating pathways for greater access, understanding, and efficacy. And so with that, I'm going to turn it over to the AMA's Director of Health Equity within our AMA's advocacy team, Jennifer Brown. She's going to provide more details on the AMA's work to address the impact of social determinants of health, the AMA's advocacy to confront and reduce chronic disease and maternal mortality, and really our leadership role in impact investing. So with that, Jennifer, let me turn it over to you.
Thank you so much, Dr. Ding, and thank you all for having me. I am super excited to be here and share some of our work with you all. Next slide. Next slide. Perfect. The AMA has worked to eliminate longstanding health inequities and improve outcomes for populations that have been historically marginalized, requires us to address sort of the root causes of maternal mortality and chronic disease and other areas of disparities as we create solutions that help us build stronger communities. And so as a result of that, I'd like to share a little bit about my background and why this work is so important to me. For those of you that are on the call or will be listening to the recording, again, my name is Jennifer Brown. I am an attorney by training. I have been with the AMA for a little bit over 7 years. I'm originally from Texas and went to law school in New Orleans. And during my time in the South, both in Texas and Louisiana, I saw firsthand how zip codes where you live matters, what your educational background is matters, how much education you've been able to obtain matters, whether or not you have grocery stores and opportunities for healthy foods and vegetables around you, and the cost of those matters. And so I have made it sort of my mission here at the AMA to work with my colleagues to address some of those social determinants of health issues. And we've also, in future slides I'll show, we're also addressing some of the maternal health work and the maternal mortality crisis that's going on in the United States. So I'll continue with my slides, but I just wanted to lay some of that foundation and background. Let's see. So we know that roughly half of American adults have one or more chronic condition. Heart disease, stroke, and diabetes are among the top 10 leading causes of death and disability in the U.S. Chronic diseases of course, may negatively impact health and quality of life, as Dr. Ding mentioned. And 4 trillion with a T annual U.S. healthcare spending. Out of that 4 trillion, about 90% of it relates to chronic disease. Next slide. So as we're talking about chronic disease, I wanted to sort of, again, lay some foundation. A lot of the work that the AMA is doing is related to high blood pressure. A lot of times that's called a silent killer because people don't know that they have it and it's not under control. And that additionally impacts maternal health as well, which I'll talk about in a later slide. So we know that Black and Latinx communities suffer disproportionately, having high levels of chronic disease, especially heart disease. That Black adults are 40% more likely than white adults to have high blood pressure, and they are less likely to have their pressure under control. Cardiovascular disease kills nearly 50,000 Black women annually, and stick a pin in that because I'll go back to that in a later slide. Nearly half of Black women 20 and older have heart diseases, but only 1 in 5 believe that she is personally at risk. And the Black community suffers disproportionately high rates of cancer deaths, although white communities have higher rates of new cancer overall. Next slide. So I told you that we are also talking about maternal health as it relates to hypertension, because as I said, hypertension can be a silent killer. We're also addressing gestational diabetes and prediabetes and other issues that can negatively impact maternal health of the mom and baby. We know that in the US, Black women are 3 to 4 times more likely to die from pregnancy-related causes than white women, and American Indian and Alaska Native women are 2 to 3 times more likely to die than white women. Medicaid covers roughly 50% of rural births. In 2018, Medicaid covers 43% of all births in the US. Medicaid covers almost 66% of births of Black women and 67% of births to American Indian and Alaska Native women. More than 90% of women deliver birth in a hospital, regardless of the insurance type. Next slide. So this slide is something that's really important to me. I wanted to have this slide in the deck because you can see that all of these women, and you probably read about this in the news as well, they passed away from either preeclampsia or eclampsia, which are heart-related health issues that are caused during pregnancy. We also are identifying that hemorrhage and sepsis are other leading causes, and we know that 80% of maternal deaths are preventable. And I wanted this slide up here because it shows Dr. Shanice Wallace. She was an MD. She was a 4th-year pediatric chief resident. She passed away of preeclampsia. Shalon Irving was an epidemiologist with the CDC. She passed away of preeclampsia. And Olympian Tori Bowie passed away of eclampsia. The maternal deaths that are occurring, they transcend education level, they transcend health and nutrition, they transcend insurance type. And so we are looking at the AMA to address maternal deaths from a clinical standpoint as well, to make sure that our physicians and our health providers and those that are non-OBs and non-fetal medicine specialists have the latest and greatest information on how to address hypertension and gestational diabetes before, during, and after pregnancy. Next slide. So we've made some progress at the federal and state level, but there's obviously still more to come. And this is personally very important to me because I almost died during childbirth for my second son from a uterine rupture. We both almost died. So I have made sure that this is a priority from an advocacy standpoint, as well as across the AMA. I'm working with colleagues to address and come up with best practices for healthcare providers, as well as elevate issues and questions that pregnant women, pregnant individuals should be asking their providers. At the federal level, we have voiced strong support for something called the Connected Moms Act, which would require the Centers for Medicaid Services to send a report to Congress that identifies barriers to coverage of remote physiologic devices, which are pulse oximeters, blood pressure cuffs, glucose monitors, etc., and provide information on barriers, as I said, barriers to care that can be addressed. At the state at the state level, we are working on addressing substance use disorder treatments. We are providing model legislation to state medical associations and other community partners that they can utilize. We're also providing a toolkit that's online that I will give you the QR code in a little bit. The AMA also joined 7 other states and national organizations to file an amicus brief that was part of a widespread effort that successfully resulted in the Ohio Court of Appeals overturning a verdict that sent a woman to prison after she disclosed that she used drugs during her pregnancy. So we're trying to impact policy on the federal and state level with both the administration and on the Hill. We're also working on, as I said, amicus briefs, but we're also trying to elevate things on a clinical level to make sure that we are impacting and providing best practices. Next slide. Nutrition is another lever that we are utilizing to try and impact social determinants of health, maternal health, nutrition for women and children and families. Next slide. Battling chronic disease is one of the 3 AMH strategic arcs. And so that is something that we are very passionate about addressing. We have in the past year commented on the scientific report of the 2025 dietary guidelines. We've commented on the WIC guidelines, the Child Nutrition Program guidelines, and these are all proposed guidelines, as well as we have a missions unit within the AMA that provides information to hospital systems and others on hypertension, which I'll share more in just a minute. Next slide. I wanted to share this slide with you all because I think it gives you sort of a good idea of the number of dollars and impact that these nutrition programs have. On communities. And so I have some numbers based on Kentucky. Just 1 second. So WIC is updated every 10 years. The dietary guidelines for Americans are updated every 10 years, and the child nutrition programs were updated in 1994 and 2010. So the AMA has been really active, as I showed on the previous slide. For Kentucky specifically, in FY 2023, over 300,000 folks from Kentucky were participating in the school breakfast program. For the school lunch program for that same fiscal year, 2023, over 450,000 Kentuckians were participating in the school lunch program. So this impacts every state. This impacts indigenous communities as well. And so we have been very active in making sure that we speak to the administration on their nutrition policy and provide expertise from our physician members and others in the community that we consistently talk to about best practices and best nutrition habits and salt intake, sodium intake, which obviously impacts hypertension. So that's something that we've been really active in the space. Let's see. Next slide. So the AMA's commitment to impact investing, we have supported something called the West Side United. It's a Chicago-based collaborative to address the life expectancy gap. It's something that is really important to the AMA. Obviously, our headquarters are in Chicago, but we have satellite offices in various cities in the U.S. And so the West Side United Partnership, we have invested over $170 million in Chicago's West Side. The AMA is an anchor partner with a multi-year $5 million investment. And so as we talk about chronic disease, we also need to talk about some of the disparities that can result, such as life expectancy, which Dr. Ding did mention. In Chicago's downtown, individuals can expect to live to 85 years old, but in some parts of the West Side community, for those who are the most marginalized, those individuals can expect to live only to 69 years old. That's about a 16-year gap. Because Chicago's West Side and similar neighborhoods across the country have suffered from historic disinvestment and systematic inequities, sort of system level and structural change are needed to address these health inequities to improve the health of our communities. West Side United is a Chicago-based collaborative, as I said, that seeks to cut in half the life expectancy gap that exists between the city's West Side neighborhoods and downtown. Again, as an anchor partner, our multi-year $5 million investment with Westside United is part of the AMA's larger national strategy to move toward equitable solutions in medicine through policies, programs, state and federal advocacy and investments. Westside United's mission is to improve social, economic, and structural determinants of health, particularly through improving access to care and community resources, improving mental and behavioral health, and preventing and reducing chronic disease. The AMA participates in work groups focused on local procurement, hiring, and impact investing. The AMA has also contributed to the small business grant pool, career pathway initiatives, and strengthened staff capacity. Additionally, as an anchor mission partner, the AMA has provided resources and subject matter expertise to further measure Westside United's efforts on health equity. By making targeted upstream investments, the AMA believes we can improve health outcomes for children and families over the long haul and significantly increase the life expectancy for Westside United and Westside residents. Next slide, please. So one of the things that I mentioned earlier on was the elevated hypertension for Black women and others in our communities. We are partners with others, such as the National Medical Association, on a campaign called Release the Pressure. And this is sort of near and dear to my heart. Every time I go on the Hill or talk to folks in the administration or with state surgeon generals, I always make sure to leave some information and QR codes and flyers on this. So far, we have about 78,000 people, women that are registered for the Release the Pressure campaign and have their squad. The AMA is also investing in community events such as healthy eating, yoga, other community events in different parts of the country. Right, I think after the pandemic, we had an event in Kentucky with our Release the Pressure campaign. And so we have been reaching out to different states to try and increase those numbers from 78,000. We hope to have 140,000 folks registered for the Release the Pressure campaign over the next year or two. So that they can have their heart squad and monitor their blood pressure, talk to their healthcare providers about that, and make sure that they are checking their blood pressure regularly. I also mentioned our mission-driven units. At the AMA, we have a unit called the Improving Health Outcomes Unit. They have been working to convene the first ever national group of providers, cardiologists, OB-GYNs, fetal medicine specialists, and others who provide care to pregnant individuals who have hypertension, to develop best practices for postpartum care for hypertension. And so they should be releasing information both for providers as well as patients in the next year. They also work closely, as I said, with hospital systems in their MAT-BP program to ensure that hospital systems have the technology as well as the processes in place so that they don't have readmissions for hypertension. And so they've been working with several states on that. I know that they've been working with the Kentucky Department of Public Health to ensure that they have processes in place to make sure that physicians and other healthcare providers have information on self-measured blood pressure to provide individuals who are on Medicaid or are interested in getting on Medicaid. So we have been actively involved at the state level as well as the federal level to elevate much of our work related to high blood pressure and other chronic care diseases. Next slide. The AMA's maternal health work is pretty extensive. We've been working, as I said, across the AMA's different units, as well as with other community partners. And so you can scan the QR code on the screen to learn more. And we also have our nutrition policy from our letters that we've drafted to the Hill, to letters that we've drafted to the administration. Some of our state work and our amicus briefs are on the website, and we update it regularly. So as we continue to support pieces of legislation as they're introduced on the federal level, that will be on the website, as well as our comprehensive list of recommendations at the federal level. That includes things like supporting medical legal partnerships. Georgetown Law has a great perinatal medical legal partnership where the law students and the medical students support patients who are pregnant or postpartum to help them navigate either the healthcare system or if they have, for example, lead in their home and they need help with that. So we are elevating more funding, increased funding for these medical legal partnerships. We are also asking for more funding for AIMS bundles. These are core AIMS bundles developed by ACOG, the organization that supports obstetricians, gynecologists, and fetal medicine specialists and others. And they have some core AIM bundles that hospitals can implement to support pregnant people while they are going through labor. And these things include hemorrhage carts and access to blood banks. And so we are supporting that, and we are supporting increased funding in that. A lot of hospitals get grants to implement some of these things, but the grants end after a couple of years and they can't continue with the grant. So we are continuing to fight for more funding for that. We are also looking at telehealth, supporting telehealth because our self-measured blood pressure, as we push that up, towards the Hill and with the administration, we want to make sure that there are broadband opportunities and telehealth opportunities that are still ongoing. And so that's something that we've been really passionate about here at the AMA to make sure that that is embedded in communities. And so there are other recommendations. That's just a brief snapshot. But the list of about, maybe 25 recommendations or so is on the website, and you can learn more about each one of those in a more comprehensive document that I think is about 25 to 30 pages. So I will, next slide. Oh, perfect. So in closing, I know that this was a great deal to cover in a short period, and we will not be able to solve all of our social determinants of health challenges and policy challenges on this webinar. It will obviously take a sustained effort and a continued engagement. It will take each of you and all of you to help us create the future that we want. And on behalf of the AMA, we thank you for being part of the solutions. And I think we're happy to take questions now, or I'll turn it back over to Allie.
Yes, if anyone has any questions, feel free to put that in the chat. I do have a few that I'm going to kick us off with. Dr. Ding, can you talk about the role that social determinants play in your approach to the delivery of care? Or maybe do you have a noteworthy experience where they dictated the outcome of your patient?
Yeah, I think it's helpful to couch this in the term of maybe a clinical scenario to kind of make this feel a little bit more concrete. And so, I just think about patients I've taken care of in the past and think of the ways in which social determinants have kind of intersected or interfered with or caused caused some um, abilities for patients not to get optimal results and outcomes. And so, as I'm an interventional radiologist, and so I focus on minimally invasive, image guided procedures that are oftentimes focused on the blood vessels. So, I've got a patient who's in their mid to late 50s. They've got um, bad lifestyle, diet, exercise, smoker, and they've got what we call peripheral artery disease. That is, their blood vessels are narrowed in their legs, and their legs and feet are not getting enough blood, and that is at risk. That puts them at risk for um, getting ulcers and problems with walking, and puts them at high risk for amputation. So one of the things that I do as an interventional radiologist is I can go in, open up that blood vessel and get the blood flowing again. One of the things that you would then expect is that things would get better with regard to their ulcers and their pain and things like that. But with a patient who's got significant social determinants of health, I can remember a patient who had this scenario. They came in, but things weren't looking any better at all. In fact, the foot ulcer that they had look perhaps a little bit worse. And so the wound healing that you would have expected with the open blood vessel seemed to be compromised. And so, you know, what I found in talking more with the patient is that they didn't have a way to get to their wound care appointments. They weren't able to afford all of the medications that were prescribed and necessary for the recovery. And so his limited transportation, the financial strain, the lack of stable support system really meant that he wasn't getting the necessary wound care, the antibiotic, the physical therapy, which then put him at risk for reinfection, rehospitalization, and then eventually risk for amputation. I think that reinforced a critical truth for me in understanding social determinants of health, which is that the success of a medical procedure that I can provide, everything can go perfectly in the angiography suite in the procedure room, but it extends into the patient's home, their access to care, and their ability to adhere to treatment. And if those things are affected by social determinants of health that are not addressed, you're going to get suboptimal outcomes, and patients aren't going to be able to get the full benefit of what we can offer them just from clinical care or medical care.
You. Jennifer, when it comes to changes related to nutrition, can you talk a little bit more about the AMA's advocacy in that area, and maybe do any cultural changes impact that?
They do. In our most recent comment letter related to the school lunch program, the free and reduced lunch program, we did provide extensive comments related to cultural preferences. So just for me, for example, the AMA has policy related to alternatives to dairy so that parents don't have to go get a note specifically from a healthcare provider to be able to have the school offer alternatives to cow's milk. And so that is personal for me because my son has some dairy issues. And so I wanted to make sure that we provided some alternatives to the federal agency that had good nutritional support, but were alternatives to regular milk. That from a statutory standpoint, they didn't need to go get a letter or any type of other documentation. So that's one aspect, because we know that a lot of communities of color have lactose intolerance. So that we wanted to highlight that in our comments. The other thing that we wanted to make sure that we provided was for American Indian Alaska Native populations. Sometimes they have specific cultural dietary preferences. And so we wanted to make sure that the administration understood that those should also be approved for the list of of dietary options for folks because they may have a root vegetable or something that is in their community that they would like to eat that should be included. So that's something that we've been really active in that space to make sure that cultural preferences are adopted.
Thank you. One question we got, I believe this one is for Dr. Ding. Can you talk any more about the work to reduce gun violence, maybe specifically here in Kentucky? Have you been working with any organizations that are local to Kentucky, Anna?
Yeah, thanks so much for that question. I see that from Tom. Thanks so much for the question. The AMA is deeply committed to addressing gun violence as a public health crisis, and our focus has been on evidence-based advocacy, policy development, and coalition building to drive meaningful change. We have been perhaps more focused at the national or the federal level. And so, as we talk about some of the ways in which we can support and contribute and play a role at the state level, for example, with these conversations in Kentucky, we often work in close partnership with our closely partnered state medical association. So, for example, in the case of Kentucky, it would be the Kentucky Medical Association, of which I'm also a member, and do some work through. But overall, I would say, what we've really been trying to kind of do from a high level is one, advancing research and data-driven policy. I think one of the things we really see as a big gap is that there's not enough research into gun violence. A big part of that had been that there was a lack or a ban on federal funding for this work for a long time. That thing or agencies now like the CDC and the NIH are now supporting and budgeted for to really better understand those risk factors, those interventions that work. We're also dedicated to promoting sensible firearm policies. We advocate for things like universal background checks, extreme risk protection orders, also known as ERPOs, and closing some loopholes that allow individuals at high risk of violence to access firearms. We work within the world of healthcare as well to work to expand physician education on firearm safety counseling, supporting clinicians and having these informed, non-judgmental discussions with their patients about how to manage this from a risk perspective. But we're also really focused on kind of expanding this work into the community. And so we've been strengthening, building partnerships with violence intervention programs. As I mentioned, that program with the Ad Council to focus more on kind of some of the communications piece of it and really to expand that public awareness and education piece of it as well.
Thank you. Another question we got, and I'm going to ask this to both of you. Has the AMA partnered with any non-traditional partners like health plans or public health departments when it comes to the social determinants of health?
Yeah, I'm going to kick this one off, Jennifer.
Sure, I can. I was just looking for my notes on that. So one of the things that we have been doing is, as I said, our Improving Health Outcomes Unit has been working directly with some of the departments of public health in the various states. I know they've worked most recently with Kentucky to get some materials produced to work on self-measured blood pressure and providing materials for both healthcare providers. But they're also working to develop materials for patients so that the healthcare providers, the physicians can post those in their offices. So maybe like a bulletin board or a handout. And we've been working to provide increase our sort of our materials that we can provide in doctors' offices and other groups on our Release the Pressure campaign, our pre-diabetes prevention, and some of our other initiatives that we're working on. One of the things that we've been doing is reaching out to sort of for the AMA, I guess, non-traditional partners. So we just finished a report on maternal healthcare deserts. So as a result of OB unit closures in Chicago, and we partnered with the March of Dimes. And so that's also published on our maternal health website that I gave the QR code for. And so we're doing more of that. We're reaching out to sort of universities and looking at some data, and we're trying to partner with some non-traditional groups. We've also been, and I know my office personally has been reaching out to some of the state surgeon generals to elevate some of the work and find out what they're doing. I know California's been really active in the maternal health space recently, and we've been reaching out and talking to them. And so we're working. We're trying to like spread our little tentacles and get into non-traditional spaces and places as we can.
Yeah, and I would just add that I think one of the interesting things about, when you think about social determinants of health is, as I mentioned earlier in my talk, there are so many components that are related to social things that impact a person's health. And so you can really broaden your scope of what it means to think about health and addressing social determinants of health. And so, whereas traditionally we would be more focused on perhaps those that are more close to the clinical and the medical care. So working with clinicians and health systems um, and public health departments, I think our focus on social determinants of health has really given us that opportunity to think about what are those non-traditional partners to really work with community organizations, with social impact organizations. As Jennifer mentioned, some of the things that we're investing in with our impact investing really gives us that opportunity to work with so many new partners that we traditionally have not, which I think really expands our universe of our ability to work together and influence and kind of address this bigger issue of social determinants, which is much bigger than just kind of the narrow scope of healthcare itself. And so I love that question. And I love that this has given us that opportunity to find these new partners to work with.
You. Well, we are about out of time. So, Dr. Ding, Jennifer, I can't thank you both enough for the presentations you gave and the time and energy you put getting ready for it today. Thank you to everyone who joined. I hope you found it as helpful as I did. And so, with that, have a great rest of the afternoon, and thank you all again.
Thank you so much for having us.
Thank you.